Petition, Upton Heath.
I beg to move that this House do now adjourn.
The question is that this House do now adjourn. Dr Scott Arthur.
Thank you, Madam Deputy Speaker, and I'm grateful for the opportunity to bring this vital issue to the House today. The term neuroendocrine cancer may not be familiar to many, but tens of thousands of people across the United Kingdom have had to educate themselves after receiving a diagnosis. As with any rare cancer, this is often an uphill struggle, marked by delays, misdiagnosis, and a persistent struggle for visibility within our healthcare system. Members, possibly including the Minister, will have heard me make this point before. A cancer being considered rare does not stop it from impacting on many thousands of people right across the UK. Indeed, around 6,000 people are diagnosed with neuroendocrine cancer each year in the UK, which works out at roughly one person every 90 minutes. Today in the UK, more than 36,000 people are living with this condition. To put that into perspective, it is now more prevalent than stomach or pancreatic cancer. The rate of growth is incredibly alarming. Between 1995 and 2018, the incidence of neuroendocrine cancer increased by a staggering 371%. This is not a niche healthcare concern, it is a rapidly growing challenge that our NHS must be equipped to meet. Statistics can often feel abstract in this chamber, which is why I want to share the story of a meeting I recently held with 3 neuroendocrine cancer patients, Liz, Carolyn and Craig, at my office in Frinton Bridge in Edinburgh South West. Their stories were both moving and illuminating. And I have to say, this meeting took place just 4 weeks ago. We've just been talking about modernising the House of Commons here. I find it quite incredible that in a 4-week period I can meet someone, request a debate, and then have my favourite minister here in the House of Commons answering the questions that I might raise. I think it's really to restore my faith in democracy. Craig, who I met that day, is unique and challenging, has the unique and challenged position of being both a professional advocate and a patient himself. He and the others I met with spoke and expressed immense gratitude for the care they eventually received, describing it as nothing short of fantastic once they were in the right hands. However, they also spoke about the exhausting battle it took to access specialists who properly understood their condition. They described a system where specialist doctors and centres of excellence are too often hidden behind a wall of referral delays and low clinical awareness. This is particularly in evidence in Scotland, where patients are currently facing the worst waiting times since records began. But it's also true, albeit possibly to a lesser extent, in our health systems south of the border and in Wales and Northern Ireland. One of the most powerful parts of our conversation centred on a symptom which is often difficult to discuss, yet utterly debilitating: the frequent and urgent need to access a toilet. This isn't just a minor inconvenience, it's a symptom that robs people of their autonomy and their dignity. They spoke of how this invisible burden prevented many patients from working, from entering social events, or even leaving their home for long periods of time. It is a barrier to a normal, fulfilling life. But they also brought a message of hope regarding the drug Telorestrat. They described how this treatment has quite literally given them back their lives by managing these symptoms and stopping the cycle of incontinence. This drug has allowed them to return to work, to contribute to their communities and pay their tax, which is quite important, and most importantly, enjoy a fulfilling family life. This is a clear example of where the right medication doesn't just treat a disease, it restores a person's dignity and their place in society. It's a powerful reminder that when we invest in the right treatments and pathways, the system burden is reduced because patients are empowered to live independently. Despite these successes, Madam Deputy Speaker, the single biggest driver of poor outcomes remains the time it takes to get that initial diagnosis. At a meeting I attended at the Royal College of General Practitioners in December, bringing together UK-based healthcare professionals involved in trials, patient care and leading research into neuroendocrine cancer, I heard that on average it takes 4.5 years for a patient with the tumour to be correctly diagnosed. During that time, the average patient visits their GP 11 times. Because these cancers can occur anywhere in the body and the symptoms are often non-specific, They are frequently dismissed as more common conditions such as irritable bowel syndrome, asthma, the menopause or anxiety. And I do hope somebody somewhere has taken a list of all the conditions which do get confused with menopause, because I do think it's quite a long one. Many patients, including the 3 who came to visit my office, look perfectly well, even while harbouring the disease. The consequences are severe, however. Over half of all patients are diagnosed at stage 3 or 4, when treatment options are more limited and the cost of the NHS is significantly higher. Neuroendocrine Cancer UK estimates that it costs between £200,000 and £300,000 more per patient when treating at a later stage rather than an early one. Currently, the UK has 13 accredited centres of excellence, including a specialist team in Edinburgh and an accredited centre in Glasgow. These hubs deliver multidisciplinary, evidence-based care that is proven to improve survival rates. Yet, access remains a postcode lottery. Whether you're a patient in rural Scotland or a coastal town in England, the quality of care you receive should not depend on whether your local hospital happens to have a neuroendocrine lead. In Scotland, we see a stark divide between our urban hubs and rural communities, whereas in England, the access issue is more related to divergent priorities of different cancer alliances. In both cases, patients suffer because we do not have a standardised diagnostic pathway for everyone. The closest we have to a standardised service, which all neuroendocrine patients can access, is one that is offered by Neuroendocrine Cancer UK. They provide a critical safety net, offering helplines, counselling and peer support. And they regularly step up to fund small-scale early-stage studies or trials which are needed to get research off the ground. It's sobering that 95% of Neuroendocrine Cancer UK's income comes from community generosity. They are delivering system-critical services that support the NHS, yet they do so with almost no statutory resourcing. In closing, I would like to ask the Minister to address 5 specific priority areas. 1. Clinical awareness. Can we embed neuroendocrine cancer into primary care training and early diagnosis initiatives to stop these patients being lost in the system for years? Perhaps reducing the number of GP appointments needed before a diagnosis. 2. Clear pathways. As I mentioned previously, we need to tackle the postcode lottery when it comes to treatment. And the only way to do this is through a nationally recognised diagnostic and referral pathway to centres of excellence. Can this be considered? 3. The guidance gap. Currently, the NG12 guidance is critical to cancer diagnosis in England and Wales. Neuroendocrine cancer is not included in this guidance. Can we review whether there could be a way to include it? 4. Data and visibility. Neuroendocrine-specific cancer data is not routinely published. We need this in order to accurately track the incredible rate at which cases are rising and our response to that. We can also ensure that more data is published more regularly. And 5. Research equity. This issue of funding for research into rare cancers was one of the key asks that charities raised with me when I was consulting on my Rare Cancers Bill, which is now an Act. What more can we do to ensure that the Government is using all the mechanisms at its disposal to stimulate research in this rare cancers and all others that currently fall through the crack of major funding streams? So in summary, earlier recognition, clearer routes to specialist care and access to life-changing drugs have the potential to transform outcomes. I look forward to hearing the Minister's plans to make that reality. Thank you, Madam Deputy Speaker.
Minister.
Thank you very much, Madam Deputy Speaker. And I want to start by thanking my honourable friend, the member for Edinburgh South West, for securing this important debate this evening. And I'm not sure if he's aware, but we could actually go on till about 5:30, so we've got hours at our disposal if we want to continue this conversation for that long. We don't want to test Madam Deputy Speaker's patience too much, though, but we don't have to be too speedy. We can cover this properly and in depth. And I also must congratulate him for his huge achievement on the Rare Cancers Act, which received royal assent, as he knows, on the 5th of March this year, with support from right across this House and in the other place. And this government is proud to have supported the Rare Cancers Act. During its parliamentary passage, the Rare Cancers Act was described as a bill of hope, and it does give hope to all those who face a diagnosis with a rare cancer, such as those with neuroendocrine cancer. And as set out in our National Cancer Plan, we will implement the Rare Cancers Act to make it easier for rare cancer patients to be contacted about clinical trials. And this Act will help accelerate the clinical trials needed to deliver the most effective cutting-edge treatments and the highest quality care for patients facing a rare cancer diagnosis. Madam Deputy Speaker, since this government took office, around 228,000 more people are getting a cancer diagnosis on time, around 40,000 more are starting treatment on time, and rates of early diagnosis are hitting record highs. And despite these vital signs of recovery, the NHS is still failing far too many cancer patients and their families. And we know that improving outcomes for rare cancer patients is key to ensuring we make the NHS fit for the future. In February, this government published our much lauded National Cancer Plan. We now have a blueprint to shift the dial on rare and challenging cancers, including neuroendocrine cancer, underpinned by 3 key targets. First, to save 320,000 more lives by 2035, ensuring that 3 in every 4 people diagnosed in 2035 will be cancer-free or living well with cancer after 5 years. Second, we will achieve the 3 cancer performance targets by the end of March 2029. And finally, we will improve the quality of life for people with cancer. As we have heard, neuroendocrine cancer is a rare type of cancer that can develop in various organs in the body, including the pancreas, lungs and intestines. The National Disease Registration Service collects patient data on cancer, congenital anomalies and rare diseases, and provides expert analysis to support clinical teams, academics, charities and policymakers to help plan and improve treatment and healthcare in England. NDRS understands the need for statistics on neuroendocrine neoplasms and has worked with an expert working group to identify these cases in the cancer registry data. This working group has included clinical experts and charity engagement, and the first statistics on these groupings are expected to be published as part of Get Data Out in a few months. Furthermore, the National Cancer Plan is committed to improving data on rare cancers to ensure transparency and support the NHS to speed up diagnosis and treatment. To help cut cancer waiting times, we'll give trusts and cancer alliances the detailed practical information that they need, from more granular data for individual cancer types to real-time pathway insights through the Federated Data Platform. By streamlining cancer metrics, we'll shine a much brighter light on unwarranted variation in care, so issues can't be hidden and action can be taken quickly. Rare and less common cancers, including neuroendocrine cancers, are a priority for this government, and this is the first ever National Cancer Plan with a dedicated chapter on rare cancers. We know that one of the most effective ways to improve survival from cancers, including neuroendocrine cancers, is to catch it early and treat it quickly. And we know that raising awareness of symptoms is an essential part of this, which is why the NHS in England run campaigns to increase knowledge of cancer symptoms and to address barriers to acting on them. And my honourable friend mentioned the number of women told it's menopause symptoms when they first present to their GPs. And as a woman who's been in that position myself, I think he made a very good point about how many different conditions are then blamed on the menopause. The campaigns have focused on recognising a range of symptoms as well as encouraging general body awareness to help people spot symptoms across a wide range of cancers at an earlier point. And cancer alliances across the country are also engaging with their local communities to deliver campaigns, community engagement and partnership activity to increase symptom knowledge and encourage people to come forward as soon as possible if they notice they have a change in their health. So whilst I want to be clear, I've never had a cancer diagnosis blamed on the menopause, there has been lots of other things I might have went to my GP about that has been blamed on the menopause. I do want to make that clear. But also, as I know the Honourable Gentleman has done work on ovarian cancer as well. He came along to an event. He took over the hosting of it from myself when I was made a minister with ovarian cancer, and the symptoms of ovarian cancer are constantly blamed on IBS, irritable bowel syndrome, or constipation or a bad back. It happens with so many cancers, so he was really, it's a really very important point that he was making in that regard. In addition to improving awareness of neuroendocrine cancers, we are also targeting improvements to support diagnosis. The NHS in England have rolled out non-specific symptom pathways, NSS, pathways designed to speed up the diagnosis of cancer nationally. These pathways are intended to cover the cohort of patients who do not fit clearly into a single urgent cancer referral pathway, but who are nonetheless at risk of being diagnosed with cancer. These benefit the detection of all cancers, including rarer cancers, such as neuroendocrine cancers. And as announced in the National Cancer Plan earlier this year, we are prioritising access to specialist treatment and to multidisciplinary teams for all patients diagnosed with rare cancers. And this will ensure patients with neuroendocrine cancer and other rare cancers will benefit from the best evidence-based care. Furthermore, we have invested £70 million into 28 new Linac radiotherapy machines to replace older, less efficient machines. And these new machines will reduce waiting times, provide 15% more treatments and enable 27,500 more patients to be treated each year. Going forward, the NHS is also harnessing the power of AI to support oncologists to plan radiotherapy more quickly and accurately, improving contouring, reducing the risk of damage to healthy tissue, and minimising complications. And we know that research and innovation is crucial to tackling cancer, which is why we remain committed to investing in cancer research. Cancer is a major area of National Institute for Health and Care research spending, totalling £141.6 million in 24-25, reflecting its high priority. The NIHR supports research into neuroendocrine cancers, spanning research to better understand and diagnose, through to research to advance treatment options for patients. Between 2021 and 24-25, NIHR has committed £3.5 million for new research projects, alongside supporting infrastructure into neuroendocrine cancer. Activity is underway through the NIHR James Lind Alliance in partnership with the UK and Ireland Neuroendocrine Tumour Society and Neuroendocrine Cancer UK to identify priority research questions regarding neuroendocrine cancer care and treatment. And this will ensure that future research focuses on areas that matter most to parents, families and clinicians. Our research investments have the potential to shift the dial and position the UK as a leading location for cancer research. As set out in our 10-year health plan, we will make the UK a global leader in clinical research. Clinical research is one of the most powerful tools we have to improve healthcare. It helps us prevent, diagnose and treat cancer more effectively. And our vision is to embed research across the NHS, giving patients greater choice and control over their healthcare. To hold us accountable across these commitments and to drive forward progress for rare cancer patients, we will appoint a national clinical lead for rare cancers who will provide independent advice on improving outcomes. So the actions I've listed make up just a small part of our plan, which will in turn which will turn cancer from one of the biggest killers into a chronic condition that is treatable. And this will benefit our desire to improve outcomes for all cancer patients, including neuroendocrine cancer patients. In closing, Madam Deputy Speaker, can I once again thank my honourable friend, the member for Edinburgh South West, for bringing this important debate this afternoon. It looks like we are going to finish early after all. I don't want anybody to think that's through lack of interest to this important topic. But it is Thursday and people do have their constituencies to get back to, so I will not delay the House any further, but thank my honourable friend for all the work he does on rare cancers. Thank you.
The question is that this House do now adjourn. As many as are of that opinion say aye.
Aye.
The ayes have it. Order, order.